As a psychiatrist, one of the biggest mistakes I see in the treatment of OCD is this. People are technically being treated, but the medication strategy just is not right for them. So as someone who specializes in the treatment of OCD, today I want to fill you in on some very nuanced and specific OCD medication strategies that you should be aware of. And I'll also fill you in on the answer to the question many of my patients ask on the first appointment. And that's, if I start a medication for OCD, will I have to be on it forever? The answer may surprise you, but I'll get to that at the end. And for those of you who are new to the channel, welcome. I'm Dr. Robert. I'm a board-certified psychiatrist. And today we'll be talking OCD medication management. But before I even get to the medication part of things, I think it's really important to stress the importance of therapy. Because without a strong therapy foundation, medications typically only help so much. They can still greatly reduce symptoms, but not nearly to the same degree that medications and therapy will. And the most effective therapy for OCD is ERP, or Exposure Response Prevention Therapy. And the way it works is it helps you tolerate uncertainty, helps you tolerate sitting with an obsessional thought or urge and not engage in a compulsion, or even face some of the worst fears that drive your obsessions and compulsions, and sort of help your brain learn that I don't need to give in. I don't need to engage in a compulsion. I can tolerate the uncertainty, the distress, and I won't die. I'll survive this. And the medications allow for more connections to form, right? And dampens that signal. So it allows you to better engage and get more out of the ERP therapy. A very common issue I see, all too common, is I have patients come to me, sometimes with years of therapy or having just started therapy, and nothing's really getting better. If anything, things are getting worse. And too often that's because they're not seeing a therapist that specializes in ERP. And unintentionally, even though the therapist may have good intentions, they're not addressing the underlying symptoms in the most appropriate way. Sometimes even reinforcing some of the obsessional thinking spirals, which can in some situations worsen the OCD. Okay, but now let's get to the medications. And the gold standard for treatment of OCD medication-wise, always the first-line approach, is using an SSRI, or selective serotonin reuptake inhibitor. And the two that I most often start with are sertraline and fluoxetine, brand names being Zoloft and Prozac, so you may have heard of them. And the reason I start with those two is because, one, they're just easy to titrate up. They come in various doses. Insurance doesn't usually give too many issues with them, and they're relatively cheap and easy to obtain for most people. They also allow me to incrementally increase the dose and go to fairly high doses without running into major side effects, because you could get like really bad, severe sedation with a medication like Paxil, or run into cardiac side effects with a medication like Lexapro. So I tend to gravitate towards those two first. One of the most common errors I see practitioners make out there is starting patients on an SSRI and not increasing it to a high enough dosage. Because for conditions like anxiety, depression, you might be able to get away with a low to moderate dose of these medications, but for reasons we're not fully sure of still, OCD often requires a very high dose in order to really get the maximal benefit from the medication. Just to give you guys a reference range, sertraline starts off at 25 and the FDA maximum dose is 200. And for fluoxetine, it starts off at 10, FDA max is 80. What's interesting about OCD is this. Sometimes you have to go above the FDA maximum, which can sound scary to many patients and make a lot of practitioners out there uncomfortable who don't regularly treat OCD. But yes, sometimes you have to go above these ranges. And the American Psychiatric Association does acknowledge that it's okay in these situations to do this. And I would caveat, I would say those are pretty rare. I very rarely have to do that. But that is something to keep in the back pocket and that someone experienced in OCD should do. But most practitioners, I understand, wouldn't be comfortable doing that. A very challenging aspect of this process is gradually increasing the dose to an appropriate level for patients without causing side effects or intolerance or all these issues that can come with that. And that's definitely an art form that takes a lot of time and experience to hone in. Let me also fill you in on a phenomenon that's very unique to OCD. And that's that the OCD itself can latch onto the experience of the medication. Let me explain. In OCD, people can become very hyper-aware of physical sensations, be very attuned and anxious around any uncertainty that may come up. And of course, starting a medication, that can be a very scary thing, especially if someone's never done it before and they're already hesitant. So they might have a lot of anxiety, a lot of uncertainty around this. And so they might be prone to also researching a lot of potential side effects, spending a lot of time online, or just being very hyper aware to any sort of change that they may experience. So this does make them vulnerable to experience side effects in a more profound way than others, or even experience side effects that may not actually be there, but the OCD is just so latched onto, being very attuned of, am I having an upset stomach? Am I having a headache? That they almost bring on some of those issues. So a very sort of nuanced part of my job is walking people through what should they expect. And if they are experiencing a side effect, an issue, talking to me about what they are experiencing. And for me, being very open, because I always tell people about this phenomenon, right? The OCD itself may start to become very obsessive around the medication, around minor dose changes or experiences that you may be having on this dose versus that dose. So a big part of it is sitting with the uncertainty and teaching people how to decipher, what is a side effect, what isn't. What is a sign that we should pull back or stop or change medication, or perhaps wait a little bit longer. And maybe that's something I can get into in another video, because that takes a lot of nuance and there's a lot of sort of skill that goes into that. So let me know in the comments below if you want to learn more about that. And one last thing about dosing medications in OCD, the goal for me, and I tell my patients this, is always to get to the highest effective dose that doesn't cause side effects. So for one person that might be 75 of sertraline, for another person that may be 300, right? It's different for every individual. And one person may really benefit, have almost complete resolution of their symptoms on that 75 milligram dosage. The other person may still be struggling with some symptoms on the 300 milligram dosage. And both may not have any side effects, or one may have some side effects along the journey. And everybody's a unique individual. And that's why you need a doctor that specializes in this that can really sort of help you through it. Okay, but what if the SSRI isn't enough? Or it doesn't work and you can't tolerate it and you can't even take that medication? What then? Well, fear not, we have other strategies as well, other types of medications. And many psychiatrists specializing in OCD would say that the next best thing to add or replace the SSRI with would be an antipsychotic. Which I get it. I get antipsychotic, very scary word. People always, answer that by saying, but I don't have psychosis. I'm not crazy. All of these things. I get that initial concern. But I always educate people. Antipsychotics aren't just used for psychosis. They're used for depression, anxiety, PTSD, among many other conditions, especially at the lower dose range. So when antipsychotics are being used for OCD, they're typically at a much lower dosage than I would use them for someone, let's say, with schizophrenia. So much lower doses, so also lesser risk of side effects, though they do come with some more side effects than SSRIs. And I only reach for them if really necessary. And the most common ones with the most evidence behind them are aripiprazole or Abilify and risperidone or risperidone. I've definitely seen these medications, especially when added to an SSRI, greatly reduce people's symptom burden. And then if people don't want to try that, there are other options as well. And I made a whole video about this. Probably my favorite is memantine. It's used for Alzheimer's disease, or it was for a long time and still is, but now it is being used more and more often for OCD and other types of compulsive disorders. That tends to be my first go-to. I find it very effective, and I think that can be a first option that's really helpful for many people as an addition or replacement for an SSRI. But it's not a medication that many practitioners who don't specialize in OCD use often. And to be sure, there are other medications as well. Buspirone, gabapentin, many others. I won't get into all of them today, but these are the main ones. Also, let me know if you want to hear about the other options as well. So now to the common question I almost always get, and that's, will I have to be on this medication forever? And the honest answer is this: I don't know. It depends for every person. Have I had patients come to me with severe OCD and get better with therapy and medications, then come off of it, and years later are still doing fine? Yes, absolutely I have. But I've also had patients who have come and they want to try medications, stay on them for a short time, and maybe we can get a lot of symptom relief, but their symptoms just persist if the medication is reduced. And so we have to stay on a certain dosage. Will that mean months, years? It's never clear. It's different for every individual. And whenever symptoms do really improve and stay that way for months, because you don't want to just reduce the dosage or come off a medication because your symptoms are better for a month or two. You definitely want to stay on the medication. I typically advise 6 to 12 months at minimum of good symptom relief before you come down. But you can try coming down in the future. There's always that opportunity. And it's very unique to individual. So I apologize if that's not a very satisfying answer, but it really does depend that much. But I do believe that many people can at least reduce the dosage if there are side effects, but it's helping their symptoms, or come off if their symptoms have been stable for a very long time. I do kind of tell people this. This is how I kind of view it. It's that if you've gained the skills using therapy and allowed those skills to become even more pronounced, even more effective because you used medications during that therapy, there is a good chance, your brain's not going to forget those skills. It's not going to forget its ability to tolerate uncertainty, distress, fight compulsions, just because you come off the medication. So those skills, the things that you gain from therapy, they won't just be lost all of a sudden if you come off of medication. And some people, they do come off their medication, do completely well. A major stressor comes up in life and their symptoms flare. So they have to come back on the medication, maybe do a little bit more therapy, not for as long, but still get a little booster of it. Things improve again, and then they come off again. And it might be that sort of cycle throughout their life. It's always hard to tell, but that's also an option for some people. So the goal isn't necessarily lifelong medication. The goal is finding the right level of support for you, for your mind, for your life, throughout different stages of your life. All right, my friends, thanks so much for hearing me out, listening to this. I hope you found this useful, educational, and I hope the takeaway is that, treating OCD, it's nuanced. It's different for everyone because it affects everybody differently. And it does require some perseverance and persistence, and sometimes high-dose SSRIs. But so long as you have a psychiatrist that's trained and familiar with treating OCD. Because, to be honest with you, not all are. I've definitely learned that. But if you do have someone that is, that can be a huge resource in helping you through your journey, along with having a therapist that's trained in ERP. And yes, OCD can be an incredibly distressing condition, affecting people for their entire lives. But it doesn't have to be one that always has full control over your life. And thank you so much for watching to the end. I really, really appreciate it. Appreciate your attention. Please like and subscribe. Leave comments down below. I really appreciate it. And I hope to see you next week for a new mental health topic. Thanks and have a good week.